dear colleague, Dr. Jerem, will be chairing the session. I will start with my dear colleague and the eminent speaker, Dr. Muhammad Manam. He's a lecture about comparing weight loss with cardiac patients, patients with GLP agonist, started on versus bariatric surgery, versus different types of diets. Dr. Muhammad, the floor is all yours.
Thank you, Dr. Fadi. So, this is one of the most common issues we are facing in our clinics. Most of our patients, as we know, they are obese. And now we are in the era of Mounjaro and Ozempic. Everybody is coming to you. Please write for me the Mounjaro. Please write for me Ozempic. I want to lose weight. This is the main issue we are facing. So, what So we need to give a clear advice for the patients. What to give them? They are really need the surgery. They are really need to go for Ozempic or Mounjaro or just diet. So this is the crucial question we are trying to answer now and to have a clear answer for our patients. Slides, please. Okay. So as we all know that obesity is very common nowadays. It is very common in developed countries, and even now in developing countries, it is so much. So it is not now the disease of developed countries. It is the disease of developed and developing countries. So many causes can contribute to obesity. As we know, behavior as stress eating, which we are all facing due to stress in the world, and genetics. Some families, they have the obesity running in them. Environmental, the type of food people are eating, psychological and medical conditions like hypothyroidism, and intake of medications like steroids. What's complications of obesity? As we all know, patients of obesity, they have increase of cardiovascular disease, diabetes, sleep apnea, cancer, osteoarthritis, and depression. So let's classify first obesity. We have a problem here in definition of obesity. We know that obesity is excess in body weight, but you cannot say anybody who has excess body weight is obese. Like everybody of us know Big Ramy. You know how much the weight of Big Ramy? Anybody knows? 120 kilogram, and he's almost 185. Can we consider Big Ramy is obese? No, Big Ramy is not obese. Big Ramy is not obese because his waist circumference is normal. It is more muscle, not fat. So using BMI alone, like less than 18.5 is undernutrition, and normal weight up to 25. From 25 to 30, it is overweight. Above that, it's the grades of obesity is not uh, defining the obesity in a right way. We can consider the waist circumference. What's the waist circumference? It is different according to the race of you are rising from. In United States, they define the obesity if you have waist circumference in men more than 102. In ladies, if it is more than 88. But in European countries, they defined if you have waist circumference in men more than 94 centimeters, and in ladies more than 80. But in Asian races, you cannot say these numbers at all. It is above 90 centimeter, you can consider him obese. If you do in body for the patient, any patient who has fat more than 25%, he is considered to be obese. So what's the hormones playing the role in controlling obesity and weight? First is insulin. Insulin, it is a hormone controlling glucose level. We all know that. But it is also anabolic. This hormone is predisposed to the fat deposition in the abdomen. So continuous insulin spike will increase the weight of the patient. And we can do that and know how the patient has insulin resistance, but by what we call HOMA-IR. And you can download the application and calculate the insulin resistance by fasting glucose and insulin. Second hormone, there are 11 hormones by the way. Second hormone is leptin. This is the satiety hormone. When you are full, leptin is secreted, and leptin will make you feel that you are enough to eat. So it is very important. If you have leptin resistance, you will get also overweight. Cortisol, it is the hormone of the stress. Some people, they are eating well, they are doing exercise but not losing weight. Why? Because they have over secretion of cortisol. Cortisol is a stress hormone. When it increases, it will never allow you to lose weight. Estrogen, the extremities of estrogen in ladies, either it is low or high, it can cause also more accumulation of fat. Testosterone, low levels of testosterone in men will increase even the body weight, and it will end by hypogonadal obesity cycle, because when a man gain more weight and more fat cells, the secretion of testosterone is decreased and he gain more weight. So it is vicious cycle, and we should cut this cycle. Thyroid hormones, all of us know in cases of hypothyroidism, people get more weight. Ghrelin, this is the hormone opposite of leptin. This is the hormone secreted when you are hungry. And this is also crucial. If you make too much cut of the calories of the patient will has more ghrelin secretion. By the end, he will accumulate weight also. So that's why you should advise your patient not to cut calories more than 500 per day. Neuropeptide, why? This is a hormone also in the brain secreted, and it is associated with obesity. And one of the most stars of hormones now, glucagon-like peptide, the GLP. It is secreted in the stomach, and also it is secreted more to feel us we are satisfied and we are not hungry. That's why now the Ozempic and Mounjaro, it's acting with this hormone, make you feel full and stop to eat. Cholecystokine is also, this hormone is secreted also in the gut, and it is important for protein synthesis. And the growth hormone. Growth hormone also, if it is low, it is increasing the incidence of obesity. So what's the methods to lose weight? Everybody knows what the method. First one is lifestyle modification. Second one is diet and exercise, medications like Mounjaro and Ozempic, and procedures, which is either endoscopic, like balloon or application. Now they are doing with even endoscopy. They just applicate the stomach as if they make sleeve, and surgical like sleeve gastrectomy and mini bypass and combinations of methods. So now let's compare about weight loss methods. First, injections will compare about Mounjaro and Ozempic. As we all know that Mounjaro is GLP-1 and GIP agonist. It can cause up to 15 to 22% loss of body weight. Ozempic can succeed up to 15% of body weight loss. Both of them are highly effective and once weekly injection, but the problem of them is the cost and the GIT side effects. So the second method is the diet and exercise, and easily you can achieve 5 to 10%. It is non-invasive, but it needs strong desire and motivation. Gastric sleeve, which can succeed up to 25 to 30% of weight loss, and gastric bypass, which succeed in more than 30 to 35%. So now if you will guide your patient and he's decided to go for operation, first thing you should ask him, do you want something reversible or irreversible? Irreversible, you go for gastric sleeve or bypass. If the patient is diabetic, you prefer to go for gastric bypass. If non-diabetic, you see. If the patient is more sweet eater, you should go for bypass. If he's not sweet eater and bulky eater, you should go to gastric sleeve. Gastric banding is the sleeve, is like sleeve, but it is just a band they put on above the stomach, and it is reversible and can be removed and succeed to 20% of body weight loss. So let's compare the types of diet. First diet is the Mediterranean diet, which is the most healthy diet, and it focuses about whole grain and stop all of white wheat. Second one is Atkins, which is very high in protein. Third one is the ketogenic, which is not preferable for cardiac patients because it has a high percent of fat and can increase even the cholesterol. Third one is the calorie deficit, to make a 500 calorie deficit, and it can cause weight loss, but it is little bit tough and more difficult. Intermittent fasting. You should at that time fast for 16 hours and eat for 8 hours, and to limit the time you eat. Combined, you can use both of them. And by the end, using a low glycemic index food to avoid the simple carb. Now, what you expect if you lose some weight? 5% will weight loss will decrease the hypertension and the hyperglycemia, up to 10% lipid even decrease, 10 to 15% the cardiac events decrease, more than 15% reduce the mortality, and even it cause remission of type 2 diabetes. So if you lose weight at that time, 8 kilogram you lose the blood pressure, systolic blood pressure by 8.5 millimeter mercury and diastolic up to 6.5. Each 1 kilogram is associated with 0.2 loss of HbA1c. 5 to 10% weight loss will cause also decrease in the triglycerides and the lipid, and more than to 10 to 15% will improve the cardiovascular mortality and cause 21% decrease in the cardiovascular death at all. And more than 15% is associated with long-term benefits of decreasing cardiovascular mortality and even remission of diabetes and even improvement of heart failure, especially heart failure with the reserved ejection fraction, because most of these patients are obese, and the heart failure is caused mainly because of the position of glycogen and sugar inside the muscle of the cardiac muscle fibers. So this is the benefits with weight loss from 5% up to more than 15%. This is Mona Lisa before diet and after diet. And this is our plan to lose weight. Now, the tips to how to lose weight, how to play with our hormones. First, how to improve insulin sensitivity. You should exercise. One of the most important things that we should advise our cardiac patients is to do resistant exercising, not only cardio, because building muscle improve the insulin sensitivity and it improve the glycemic control of the patient and will decrease the cardiovascular risk. Improve your sleep pattern. You should sleep at least 6 to 7 hours. Change your diet to Mediterranean diets, and also you try to improve your leptin levels with the same maneuvers. Testosterone is increased by weightlifting and resistant exercise, and this is very important. Resistant exercise is very important for men and women, not only for men. Ghrelin also, you should not cut the calories too much as it will increase, and by the end you will stop losing the weight. To control your cortisol level, you should exercise and you should do some meditation. And to maintain healthy estrogen also by controlling your weight and exercise. So by the end, all hormones you can manage by adequate sleeping, exercising, cutting of the carbohydrate, and concentrating more on protein intake. Depending, now let's give the bottom line of the decision. When you have a patient who has a body weight of more than, body mass index of more than 35 and he has hypertension or diabetes, at that time you should push him for surgery, not only for Mounjaro, because in Mounjaro or Ozempic, many of patients again, they when they stop, they gain weight again. So there is failure rate is too much, and also the cost. This is the problem. It is not something maintainable. So depending on the procedure, average patients lose almost 25 to 35% and more than 70% of their fats if they do bariatric surgery. And all recent studies favor the going to bariatric surgery more than using of GLB and GIB. So this is very important message to deliver to your patients. This is the guidelines. And bariatric surgery, after that, it causes 40% decrease in the risk of heart diseases and 60% of diabetes, and even mortality is decreased by more than 60%. Here the study is done for using of Ozempic. By the way, this is a good thing in all of GLBs and GIBs. It has cardiovascular benefits. So the SUSTAIN 6 study, as we can see, it is decreasing the non-fatal MI, the stroke, and all of this. We can see that especially patients, when they use Mounjaro and Ozempic, they have the rate of revascularization is significantly lower, and the nephropathy is decreased, but on expense of retinopathy. Some patients have more retinopathy. The SUMMIT trial and the CERBAS trial, it also encouraged the use of Mounjaro for weight loss and decrease the heart failure of the patients. This is the difference between Mounjaro and Ozempic in losing weight, controlling of HbA1c and mass. And the benefits, as we said, decrease the glucose, body weight, dyslipidemia, cardiovascular protection, and even blood pressure control. We can see here that the side effects of Mounjaro and Ozempic, like nausea, vomiting, diarrhea, the most serious side effects as pancreatitis, and the most serious side effect also is losing muscle. All patients using GLB and GIB, they lose 40% of their muscles. So by the end, when they stop Mounjaro and Ozempic, these muscles is replaced by fat. So again, they will gain weight. That's why the recommendation now is not to use Mounjaro or Ozempic in body weight. Even in the face, we have something called the Ozempic and Mounjaro face. You can see they lose too much weight. This is the body fat. This is the 2022 recommendations of the bariatric and the surgery. If the patient is more than 35, now the recommendation BMI more than 35, even without comorbidities, you should go for surgery. More than 30 plus diabetes, you should go for surgery. If not sustained the body weight, you should go for surgery. Even in the children, if they have BMI more than 120% and they are diabetic, you should go for surgery. If the patient is 140% and do not have any problem, he should go for surgery. So by the end, this is the perfect plan because we are out of time. The perfect plan which I use, by the way, during COVID time, I gained 18 kilograms in 2 years. And I lost them after that, but still I need to lose more. This is the strategy I used. First one, go for Mediterranean diet, DASH diet. Use more protein, make more than 30% of your food is protein. Use food with low glycemic index, especially the things like high glycemic index like grapes, banana is high glycemic. So high glycemic, white wheat, all is high glycemic, like pasta, like bread, all of this you should avoid. Eat from farm, don't eat from factory. Simply, if you like pineapple, eat pineapple, but don't eat canned pineapple because it is too much sugar. Second thing, not use any oil except olive oil or natural butter. Before, if you remember, in 90s, they said that plant butter is useful. Now, it is the cause of all of atherosclerotic heart disease. Avoid any simple carb will cause spike of insulin. Avoid white wheat products. Make calorie deficit of 500, 14 to 16 hours of intermittent fasting. Make gap between food each meal, like at least 5 hours to avoid insulin spiking. This is all you can do for your cardiac patients before going to surgery. Sleep 6 to 7 hours, stress management, and exercising, especially resistant exercising, and make your exercise 50% resistant and exercise and 50% cardiac exercise. So our plan now, we know the patient when comes to you, if his body mass index more than 35, advice for surgery first before the GLBs. Then after that, go for the GLBs. At the end, if the patient refuses, go for diet and exercise to reach the best body morphology we need. Thank you.
Thank you very much, Dr. Mohammed. Thank you. I think we have room for a couple of questions. That was very educational, Dr. Mohammed. Yeah, please stay there. Don't go anywhere. That was really educational. I think we don't have much information about the GLP-1 agonist, and I like very much the sum up at the end. I think we can do some kind of like an educational leaflet to patients regarding the last slide. Sure. I really like it a lot because it's very simple instructions, straightforward. The patients will understand it. What type of food he should or she should take, and the calories and all the things. So it's very nice. I like it very much. One more thing, because there was a bit of concern recently, and in the BMJ, they just issued some reports on side effects regarding the tirzepatide and the semaglutide, and it caused almost like 84 deaths in UK.
Yes.
And the patients usually ask about the things. Will it kill me, doctor, or not? So I'd like to hear from you, what would you tell to the patient about this, and what precautions would you tell to the patient regarding the this GLP-1 agonist? And is it really that bad, like it can cause a lot of side effects, or we have to be cautious and follow up regularly to avoid these adverse effects?
So first, if you will start patients on the GLBs and GIBs like Mounjaro or Ozempic, you should do the thyroid function. Then you should do thyroid ultrasound. And the patient ask him if he has any family history of thyroid cancer, it's contraindicated completely. So this is the main contraindication to start this group. After that, it should be supervised by you and do the TSH level and assess the side effects. And you should instruct the patient if he had epigastric pain. Many cases, I think all of us see in the hospital, many patients admitted with pancreatitis and all of these. So if he has any side effects, serious side effects, he should go and seek medical advice. So this is the main things, and we are teaching the patient this is not a magic. You should. Some patients are really making me mad. Some patients are eating sugar and foods just to test the Monjaro, is it effective, or Ozempic is effective or no. How this, yani, you are testing the medicine in your body. So you should instruct the patient about healthy lifestyle. After the patient lose weight, he should know that when he stop Monjaro or Ozempic, there is rebound again, increase of body weight at least to 2 to 4%. So he should keep healthy lifestyle, healthy food, and exercise, and change all of his mind. It is all here, Dr. Fadi. You should change your mindset at all.
Dr. Munir, I think you have a question.
Thank you very much, Dr. Ma. It's very, very, very interesting lecture. It's everywhere in the social media. And this is the big problem about the GLP-1 receptor agonist. The problem that the power of the social media,
right?
It's unbelievable, okay? I took Monjaro, I lost 30 kilograms. Okay? I totally agree with you that changing the lifestyle would support either the Monjaro or sorry, the GLP-1 Monjaro or Wegovy or Ozempic or whatever, and also surgery, because we have a very big bariatric center in our hospital. We see complications also for the surgery, and this is not even a small complications, it's a very serious complications, and considerable number of the people who do bariatric surgery, they go back to their weight within 3 or 4 years, unless they go for the regular health lifestyle. So in my opinion, either surgery or Wegovy or Monjaro or whatever, there should be a deal for the one who's doing the surgery or who's giving the Monjaro, or the Ozempic, that it's not going to help alone. It's going to give you a big boost, and then you have to work by your own. Okay, I think why there is a lot of talk about the side effects of these drugs, because I remember a few months back we had people here, they were paying money to get their turn in the list up to get the Monjaro earlier.
It went into the black market at some point.
It went to the black market. If you go to some places, they tell you, okay, I give it to you 2,000, I give it to you 3,000, okay? And this is the only drugs which the patients are willing to pay. If you give him statins and it's not covered by his insurance, he will not pay the 100 dirham or the 200, but he's willing to pay the 1,700 or the 800 dirhams to lose weight. Okay?
And he will argue about the side effects of a statin, which will never be serious like this one.
So I think, what you actually said is right. Either surgery or injectables. He should know that he cannot stay all his life taking injections, and if he do surgery, this means that he will not, there's no chance that he will get weight again. But healthy lifestyle and exercise is the cornerstone, either here or there. I think that the side effect is more, we see it more in the side, not for the surgery, in the other side, because there is thousands. How many patients they do bariatric surgery per year in UAE? How many GLP-1 receptor agonists have been dispensed per year? Millions.
Yes.
Okay. So if you have a very, like 1% out of million, it will be much, much, much more than 1% out of 1,000. Dr. Iman, you want a question?
Dr. Ahmed, it is mindset by the end.
Yeah, exactly. 100%.
Mindset, keep healthy, change your life.
Thank you very much, Dr. Abdelmenam, for your excellent presentation. I just wanted to stress on one point already mentioned by Dr. Munir, that bariatric surgery is not magic. I've been working with bariatric teams in 2 different hospitals over the last 8 years. And I've seen lots of patients coming back, not immediately after the surgery, but let's say 2-3 years later, gaining weight, getting back to exactly the same previous weight. Because Yes, the surgeon did his part and he made the stomach small, but the patient chose to fill this small stomach with high caloric food and with sugar and so on. So he gained weight. And I would like to disagree with you that bariatric surgery is not magic. And these people who gain weight after bariatric surgery, they gave a very good response to GLP-1. I have followed many patients with from this category, and they've been using the GLP-1 with different names, and still they managed to lose 20 to 25 kilos. Of course, you have to explain to your patient that again, this GLP-1 is not magic. It's going to take 6 to 9 months, up to 1 year to get back to their normal weight. They cannot, because people think I'm going to pay 1,700 and then I'm going to lose my weight. No, they have to understand that there will be gradual increase in the dose. They will be follow up every month, follow up with dietitian, as you mentioned, the quality of their food they're eating, and they have to understand what is high caloric food, what is high sugar food, what is the glycemic index of each food. This is beyond our role in the cardiology clinic or in the internal medicine clinic. So they should follow with a dietitian. Thank you.
Thank you.
I agree with you, Doctora, completely, by the way. But from start, this is the choice of the surgeon. He should choose a good type of surgery for good patients. If the patient is sweet eaters, he should go from start for bypass, not for gastric sleeve. Some patients change their way in food. And some patients, they are bulky food eaters. After doing the bariatric surgery like gastric sleeve, they start to eat sugar more. So they gain weight. So again, by the end, the patient, if he didn't change his mindset, he will be forever, for all of his life on GLBs and GIBs. It will not make the real correction.
It's just about the sequence. You say that we go first for the bariatric surgery, second, we opt for the GLP-1 inhibitors, and third, we encourage lifestyle. We have been taught that lifestyle is the cornerstone. You go first for lifestyle modification, second you try the injectables, because the injectables you can stop them at any time, and then the last resort will be to do a bariatric surgery. You are telling us in your excellent presentation that the sequence is reversed. I'm not convinced.
No problem. The problem, Doctora, if you face many patients like this, is the failure rate. How many patients lose weight with diet and exercise and they fail and they gain weight again? How many patients on GLBs and again they gain weights? That's why the guidelines, the American guidelines, not me, said if there is BMI more than 35, you should go for surgery. Because of failure rate, not because, but as per logic, and that's what I am doing with my patients. You should change your lifestyle, because by the end, if you didn't change your mindset, if you didn't change your lifestyle, you will gain weight even if you do surgery, even if you take injections. But I'm talking about the success rate.
Thank you very much, Dr. Mohammed.
Thank you.
Dr. Walid, you have a question? Yeah, please.
Thank you, Dr. Abdelmenem, for the great presentation. I think there is a general agreement that the BMI is not now a parameter to measure obesity. So why we don't have till now an accurate measurement and evaluation for the obesity? When I go to my gym, my trainer is telling me you have 30% fat, you have to go down to 15% fat, and they have good measurement. They are checking the subcutaneous fat and they have some machines to measure this. Why in the medical field till now we don't have an accurate measurement for obesity?
You mean for the lean body weight and the extra fat and the muscles and other things, like the one in the fitness clubs and all this, right?
Muscle mass,
yes,
and the fat mass and the fat percent, and according to this, you plan the program of reducing weight for your patient. I mean, if we don't have a proper, accurate measurement for obesity, we will never be able to treat it in the right way. You agree? So my simple question for everybody, why we don't have till now an accurate tool to measure the fat content in our body?
You should not use just one tool. It is combined. As I told, Big Ramy is 120 kilogram. We cannot say he is fatty or he's obese. All of it is muscle. So you cannot use BMI in bodybuilders and these people. You should use waist circumference and fat percentage. The most accurate is fat percentage. If it is more than 25, it's obesity by the end. So by doing in-body, it is a little bit more accurate. Even waist circumference is something changing in races. You cannot say the same in American peoples, in USA, in Europe, in Asian. So it should be like combined.
But why the fat percent is not coming to the guidelines till now? We see all the guidelines speaking about the BMI still, right?
They didn't give me a chance to change this.
I think it's a rough measurement, like you said, Dr. Walid, and we cannot count only on this. But just to cut it short, because I think we're running out of time. Like you said, Dr. Muhammad, it's a very educational session, by the way. Thank you very much, and it was really interactive. Moral of the story that not only GLP-1 agonist or bariatric, we should also do lifestyle changes, and the education for the patient, I think this is supreme.
I spend at least 10 minutes if you start, and you should, all of us should do that. Just teaching him how to eat, how to live healthy lifestyle.
Thank you, Dr. Muhammad. Thank you very much. We'll move to the next speaker. Thank you.
For our next talk, we welcome Dr. Abdulrazak Al-Kadur from the Health Plus Hospital. He's a gentleman with a wealth of knowledge and is going to educate us today about something that actually goes hand in hand, which is diabetes and heart disease. Welcome, sir. We look forward.
Thank you so much. Good morning, ladies and gentlemen. It's really a pleasure to be with you. And 15 minutes, very challenging for such a subject, but I will do my best. So how do you change? Okay, so no conflict of interest. I will be talking about overview of diabetic epidemic, cardiovascular risk of diabetes, and overview of treatment of cardiovascular risk factors. Most of my slides really from the evidence of current cardiovascular disease prevention guidelines from American College of Cardiology. Diabetes, global epidemics. Millions of people affected, especially in this, our beloved part of the world. And it's getting more and more, along with obesity, as my previous speaker have said. This is obese nation. So along obesity and diabetes, really a big constellation of problems. And look at this. This is very sad. Look at the Middle East and North Africa. We're getting 86% increase. I think something we're doing wrong. I mean, compared to what's expected in North America and Caribbeans, they're going up by 23%. So 86% is tremendous pathology, a lot of death. So pre-diabetes, microvascular and macrovascular complications start even way before this occurs. So by the time diabetes is diagnosed, it's a little late in the game. And there's many mechanisms. I mean, this one slide just summarized some of them, including inflammation, infection, hyperglycemia, insulin, dyslipidemia, and thrombosis. So the sugar numbers doesn't mean much. So we have to think beyond. That's why this disease progresses and kills so many people. Diabetic patients have 10 to 20-fold increase of microvascular complications and 2 to 4% increase of macrovascular complications. Majority of diabetic patients really have mortality because of cardiovascular disease. I practiced cardiology in the US and in SKMC for a long time, but in the past 5 years, we were working in diabetic center. I never felt belong more than diabetic center. I love preventive cardiology, and unfortunately, diabetes is cardiovascular disease. On average, 50 years old man with diabetes and no history of vascular disease is 6 years younger. So he really is like lose 6 years of precious life if he's diabetic. And the East-West study that patient with diabetes with no coronary heart disease experience similar rate of myocardial infarction as patient without diabetes and coronary heart disease. So how is coronary artery disease different in diabetes? The extent multivascular disease, distal disease, our colleague interventionist really probably can agree with this. And on top of that, silent ischemia and diabetic population. Younger, especially in United Arab Emirates, we see work in the US and from looking at the literatures, our average patient with MI, coronary heart disease, and in our beloved UAE, like in their 30s or 40s. In the US, mostly in their 60s and 70s, so at least 15 years younger when they are diagnosed with ischemic heart disease or stroke, unfortunately. Women are more prone and worse outcome despite revascularization. So there is, hopefully, with next, I don't know if any speakers this talk will talk about women and heart disease, a special subject. They have increased restenosis and very different revascularization, very, very challenging. Stenos 2 study, this little bit old slide, more than 20 years, multifactorial intervention and cardiovascular disease in patients with type 2 diabetes. Intensive risk factor modification reduces cardiovascular event in diabetes. And the rest of my 10 minutes will focus on that, how we do about it. So I find this very practical, the A, B, C, D, I added E and S approach. So we'll talk a little bit briefly about how do we get A1C optimal glycemic control, how do we deal with blood pressure management in diabetic population, and cholesterol and drugs to protect the heart. So any medicine we give to a diabetic patient, we have to think about the heart first. It's not only the number how to treat diabetic patients. Of course, exercise and smoking cessation. Those of you who knows me knows how much passionate about this, And then a few slides about heart failure and diabetes. 12-lead ECG, very inexpensive, old technology, very crucial, very important. Every diabetic patient, at least once a year, if not more than that, he should get this ECG, very valuable. Exercise stress test. I think this study from Mayo Clinic tell us that the impact of stress testing in screening patients who are asymptomatic, at least once a year or once every 2 years. And I think this is valid, although it's not in the all guidelines, but it was done in community-based cohort study, and they found that associated with improved long-term free survival, you pick up pathology early with simple technology. So we'll go to the ABC. Hemoglobin A1C goal of less than 7%, and close to normal, better less than 6%, and avoid hypoglycemia. We know that from the DCCT trial that intensive glycemic control in diabetic patients reduces risk of microvascular complications. And this, for type 2 diabetes, UKBDS told us that intensive control of diabetic patients reduces risk of microvascular complications. Well, our old friend biguanide, metformin, very, very important, very inexpensive drug, still have big role, but probably should be used in low-risk diabetic population. So it should be probably the first choice to consider for a patient with diabetes, still 2A, and so somebody overweight without associated risk factors. Now, how about patients who are already on metformin who did not achieve target? If they are low risk, then you add SGLT2 inhibitors. But if they are high risk, I think recommendation now to go ahead and start with SGLT2 inhibitors or GLP-1 agonists. So those medications are recommended in patients on metformin with cardiovascular disease, or you can start with them if somebody diabetic with cardiovascular disease, you can skip metformin and start those medications. How about somebody drug-naive patient, brand new patient come to you? High-risk patient, you start as GLP-2 inhibitors or GLP-1 agonists. So I think it's almost malpractice not to do so. I mean, you see some people come, being diabetic, they are, most of our patients are high-risk population. I mean, they're overweight, probably smokers, have hypertension, family history. I really think majority of our diabetic patients should be on one of those medications, a GL2 or a GLP-1 agonist. We have plenty of data. There are at least this large 3 randomized studies telling us that using SGLT2 inhibitors reduces cardiovascular death, non-fatal MI, or non-fatal stroke. Same thing goes for GLP-1 agonist. We have 3 big studies among others, but I thought because of sake of time, again, give us the same guidelines. So safe medications, previous speakers talk about the probable side effect. What do we tell our patient? What do we expect? Blood pressure should be measured every routine visit. We should be assertive of controlling blood pressure in diabetic population like the way we are assertive in pregnant ladies. We have to be careful. We are too busy. A lot of patients come, their blood pressure 140, 145, we oversee that. I think the systolic blood pressure should be less than 130, the diastolic less than 80. And we have HOT study among others, greater benefit with more intensive blood pressure control and diabetes. This study again tells us that blood pressure control greater cardiovascular risk reduction than glycemic control. Who should receive ACE or ARB therapy, regardless of baseline blood pressure? Any patient with clinical cardiovascular disease, age of 55 or more, and additional risk factors, and presence of retinopathy, albuminuria, or LVH by echo should be considered for ACE or ARB, even blood pressure borderline normal. With this study telling us that use of ACE inhibitors in most trials in diabetes associated with the reduction of adverse cardiovascular outcome. Treatment ARB carries lowest risk of developing the diabetes. So again, I think it's malpractice not to see it on the prescription of diabetic population. Addition of renin inhibitor does not reduce cardiovascular event. Beta blocker does not have additional role unless the patient have indication, previous MI or stroke or arrhythmias. Statin therapy should be lifestyle therapy regardless of baseline. Every diabetic patient should be on statin. If did not achieve, you add ezetimibe. If not, then you can go to BKS9 inhibitors. It's contraindicated in pregnancy or lactation. I think we spoke about this yesterday, one of the speakers. Fibrate does not provide significant additional benefits in diabetic population. Aspirin is not routinely used in diabetic population unless they have additional risk factors. Exercise, of course, my previous speaker spoke about it. Lifestyle is so important. Smoking, I think all patients should be avoid smoking. I think you should spend 30 minutes, what we call quick advice, ask, advise, and refer. I think we overlook that. It's so important. I think patients come, we take care of diabetes, hypertension. We are the smokers. I think we should advise them assertively or refer them to tobacco cessation program. Heart failure. I think a lot of data in the last 2-3 years telling us we have to how to predict early heart failure, because diabetes is major risk factor. 14% of people with diabetes develop heart failure. And I think very simple now, class 1 indication to order NT-proBNP and cardiovascular risk assessment of diabetes at least annually. And I think the number, if it's high, then you go forward and to abnormal biomarkers defined stage B heart failure, even if the patient is asymptomatic. So screening is so important. It's asymptomatic individuals in diabetes with abnormal BNP recommend to identify further and do further things. So in conclusion, ladies and gentlemen, lifestyle again, so important to control hemoglobin A1C, control blood pressure, tobacco cessation, exercise, weight reduction, and thank you so much.
But sir, if anyone has any questions in the audience.
Thank you, Dr. Kadur, for the great presentation, as usual. I need to know your experience about keeping this strict recommendation of the blood pressure below 130/80. we are facing a lot of resistance from our patient and from the population in general. I remember I was in a TV interview and I mentioned this classification, and I got attacked in a very offensive way by people insulting me that this is nonsense. So how compliant are the patient to accept keeping their blood pressure below 130/80 in your practice?
This is very important. I think education and what we call aware patient, well-informed patient is the best patient. I think talking to him about this is silent killer, and empower him, understand, and give him what we call home sphygmometer. Most insurance now give him this 200, 300 dirham mechanism, and not to focus on the blood pressure in the office. And so when he's aware of this and he knows this silent killer, and controlling blood pressure will avoid retinopathy, stroke, cardiac problem, and kidney problem, then he will be willing to cooperate. But if you just tell him what we call finger approach, take your blood pressure, this is bad, you should take this medicine, goodbye, next patient, he will not do it.
What about the age factor? I mean, we should keep this 130/80 recommendation even in older age group?
This is the 30 years old practice. Long time ago, we thought every decade is allowed to have 10 millimeter of mercury, not anymore. I think this age is not, actually we have to be more assertive in older population. I'm not saying 85 years old should have blood pressure 110, but I think still 130/80 is the recommended now for all ages.
Thank you, sir. If there are no more questions, thank you very much for the wonderful lecture. We'll move on to our next speaker.
Thank you very much. Next speaker, Dr. Iman Hassan, our dear colleague, eminent speaker, Dr. Iman Azmat. Dr. Iman will talk about resistant hypertension, updated guidelines and case presentation. I think it's a bit of a hassle of a subject because what's more important, even not only the treatment, the investigations, which are a bit sophisticated. So I'm sure that will be a very interactive session. The floor is all yours.
Morning, thank you. Thank you, dear colleagues, for coming up on your weekends. I hope it's going to be a fruitful meeting. Thank you, Mr. Chairman. My talk today will be about the resistant hypertension. We'll be talking about the definition. We'll review together the updated guidelines of 2024 by European Society of Cardiology, and we'll be presenting a case. This is the situation here in United Arab Emirates as per the WHO review. For the hypertension profile, we can see that age standardized prevalence of hypertension among adults. Unfortunately, we have 40% of adults aged between 30 and 79, they have hypertension, compared to a global of 30%. As for the uncontrolled population among these hypertensive patients, we're talking about, again, 35% of the hypertensive population, they are still uncontrolled in UAE. This is a review of the updated European Society of Cardiology guidelines. The current definition of resistant hypertension, if your patient is on maximum tolerated dose of a diuretic, a RAS blocker, calcium channel blocker, and still his blood pressure is above 140/90. What are we considering? Why are we talking about this resistant hypertension? Because these people, they are at high risk of cardiovascular disease. So even when they are on maximum doses and they are well controlled, we still call them controlled resistant hypertension. They are at target, but they are requiring more than 4 medications. And we call them refractory hypertension if the blood pressure is still not reaching the target, although they are on 5 medications. We should be aware before classifying our patient as having resistant hypertension, we should take careful history of him. Maybe it's poor adherence. Maybe it's white coat phenomena. When he comes to your clinic, he has high blood pressure, but his blood pressure is well controlled at home. Maybe he's using poor blood pressure management. He has brachial artery calcification. or maybe it's just clinician inertia, like he's been seeing his physician regularly and his physician was just renewing the amlodipine 5 without giving him the maximum dose to control his blood pressure. Another possible causes of resistant hypertension that we should discuss with our patient is overweight and obesity. As mentioned by Dr. Abdelmenam, it really affects his blood pressure. The physical inactivity, if he's using excess daily dietary sodium and excess alcohol, and if he's using any other medication that might affect his blood pressure, as the non-steroidal and the analgesic, they are tending to increase the blood pressure in many patients. Or we should suspect secondary hypertension and refer him to our colleagues, the endocrinologist, to work on it more. As per the recommendation of the guidelines, we should document the out-of-the-office blood pressure measurement to rule out the white coat hypertension and the masked hypertension. So it is recommended as class 1A to check the BP of your patient at home. Don't rely only on the blood pressure that you check in your clinic. We should encourage our patient to use the ambulatory blood pressure monitoring. If you have it in your clinic, it's very beneficial. It will be adjusted to check the BP of the patient at home every half an hour automatically, and after 12 midnight, it's adjusted to check his BP every hour. The information that we will get from this ambulatory blood pressure monitoring is very valuable and will affect the management of your patient. The ambulatory blood pressure, it can identify white coat hypertension, people who come to the hospital with high blood pressure, but it's well controlled at home. It has a stronger prognostic evidence. It will check his BP even when he's sleeping. Nighttime reading is very important because it will define your patient whether he is a dipper or non-dipper. Those who do not have a normal blood pressure reading during sleep are considered as non-dipper, and this is a very high risk category, and it will affect the management of your patient. The problem is it might affect the quality of his sleep, and it's not available in every clinic. But we're talking here about a specific category of patient, which is the resistant hypertension. So please, if you don't have this modality in your clinic, you can at least refer him to a specialized clinic with ambulatory blood pressure monitoring. When we use the out-of-the-office measurement, our target to diagnose the patient whether he's hypertensive or no is not 140/90. Out-of-the-office assessment, if you're using a 24 hours blood pressure monitoring, if the patient has more than 130/80, he's considered hypertensive. And if his nighttime measurement of BP is above 120/70, he's considered hypertensive. Again, class 1A, self-measurement, when properly performed, it has a positive effect on the acceptance of diagnosis of hypertension, patient empowerment, and adherence to treatment. So your patient will always resist you adding another medication, changing his medication. So what I do, I recommend my patient to check his BP at home. When he checks at home, and he will be surprised with the readings that he will get at home, when he comes on the next visit, he will be willing to accept your new medication and your new recommendation. This is by the guidelines, and you will get the question from your patient, which device should I use? What is the recommended? There is a site called validatebp.com. On this site, they put lots of brands and lots of machines that are validated. And I can simply ask the patient to bring his own machine on the next visit and compare it to our machine reading. If it's the same, or at least we'll know that there is an error of plus 5%, minus 5%, he can still use it at home. And we have cheap machines now in the market as cheap as 100 dirham. And it's worth investment. And many medical insurance, they cover the blood pressure devices, the home devices. The patient sometimes pays for it and then he reimburses from his insurance company. So this is really important as per guidelines for your patient to check his blood pressure at home. So again, we should consider the secondary hypertension. Whenever we have a patient with resistant hypertension, please consider it, refer him to endocrinologist so he can work on it thoroughly. You should also screen for primary hyperaldosteronism and refer him to endocrinologist. Sodium restriction is very important, and you should talk to your patient about this. It's really important. Many patients, they use pickles, they use chips, they use salted nuts, and this is affecting their blood pressure. Aerobic exercise is important, more than 30 minutes, 5 to 7 days per week. Maintaining a healthy body mass index between 20 and 25, and using healthy balanced diet as the Mediterranean or DASH diets. Again, it's important to maintain the blood pressure. All of these are class 1 indication as per guidelines. For the pharmacological treatment, the recommendation of the European Society of Cardiology is to start ACE, ARB, of course, one of them, dihydropyridines, calcium channel blocker, diuretics, and they mentioned all types of diuretics, thiazide, chlorthalidone, indapamide. These are the most effective drug to control the blood pressure of your patients. Beta blocker, of course, they still have their role, especially among patients with heart failure, post-MI, and for heart rate control. When to use the medication, morning, doctor, or at bedtime? We get this question many times from our patient. The answer is, as per the guidelines, at the most convenient time of the day. It doesn't make a difference. Anyway, the medication is working for 24 hours. If he tends to forget and he will remember better at bedtime, it's fine. If he prefers to use it in the morning, it's fine. Unless you do an ambulatory blood pressure for your patient and you find out that he's non-dipper. If you have this finding in the ambulatory blood pressure, it's preferred to use the antihypertensive at bedtime. And please go for the fixed dose single pill combination, because patients, they are forgetting, they are already diabetic, dyslipidemic, they have lots of medications. So if you can simplify his life and go for combination for amlodipine with valsartan, telmisartan with amlodipine, chlorthalidone with azilsartan, whatever combination you find convenient to your patient with resistant hypertension, please use it to improve the adherence and compliance of your patient. Another important category of patients are the old, frail patients. These patients are very fragile. You have to consider what type of other medication they're using. If he's an old man, maybe he's using a prostate-specific alpha blocker. You should consider if he's using other medication like non-steroidal, if he's using sedatives at bedtime. All these medications should be considered. What I do with my patient, I ask him to bring the bag of his medication with him on every visit. And you will be surprised when he puts all these boxes in front of you, you will be surprised. Some of them are using omeprazole and pantoprazole at the same time, Amvasc and Norvasc at the same time. So please let your patient bring all his medication, supplements, anything he's using, to be sure about the types of medication he's using and whether it's affecting the antihypertensive regimen you're giving him or no. The updated guidelines, they are stressing on that screening office blood pressure 140 to 160/90 is recommended for diagnosis of hypertension, and they are still stressing on the importance of the out-of-the-office measurement, whether ambulatory blood pressure or home devices. Among all the blood pressure lowering drugs, the priority is still for ACE, ARB, dihydropyridine, calcium channel blocker, and the diuretic, including thiazide and chlorthalidone. They are the most effective class 1A. So consider these medications to control the blood pressure of your patient as per guidelines. ACE and ARB are really important for your diabetic patient to help them for the microalbuminuria. They have a renoprotective effect, so they should be your first choice in diabetic patient or even in any patient with microalbuminuria. Patient with resistant hypertension, consider adding spironolactone to their regimen of medication. This is class 2A per guidelines. Patient with resistant hypertension, again, after using the previous medication, add beta blocker. If they are still uncontrolled, consider the centrally acting blood pressure lowering, consider the alpha blocker, consider potassium sparing diuretic, consider all the weapons that you have. But please make sure that you add one medication at a time. If you find your blood pressure, the blood pressure of your patient uncontrolled, don't rush into adding too many medication. I'll see you in 1 month, take this and this and this. Your patient might go into hypotension, orthostatic hypotension, especially if he's an old patient. So please add one medication at a time. Follow your patient at regular interval, short interval, and explain to him that this is only temporary until your blood pressure is controlled, and then I'll keep seeing you for refill every 3 months. For your patients, it's recommended to do them an echo if it's needed, if they have abnormal ECG, coronary calcium score considered in some of them, carotid pulsed wave Doppler or brachial artery pulsed wave Doppler in some of them, considered cardiac troponin. Ankle brachial index is an easy device. It can be done at your outpatient clinic and it affects the response. Abdominal ultrasound and fundoscopy. It's really important to send your hypertensive patient to the ophthalmologist at least twice per year to do fundus examination. And you should explain to your patient, it's not about reading glasses, it's not about your glasses, it's about your fundus, to uncover the retinopathy and manage it as early as we can. This is again spironolactone to be added and considered for them. 12 leads ECG class 1 to be done to all hypertensive patients, and echo if we have an abnormal ECG. Our case today is Mrs. M. She's 75 years old. She's been hypertensive for 25 years. This is her blood pressure, 180/90. Her heart rate is 60, and this is her current medication. A combination of amlodipine, valsartan, 5/160. She's on atenolol, and she's on thiazide diuretic once daily. The patient, when we see such patient, we should start assessing her. Whether she needs admission, is it an emergency? Does she have any dizziness, blurry vision, vomiting, numbness? Should we admit her, or it can be she can be managed as an outpatient at the outpatient clinic? What is her reading at home? Is she really compliant on her medication? Is she using extra salt? Is she using any other medication? In our case, the patient had a very lovely, caring daughter who was taking care of her. She was sure about the medication timing. She even adjusted her mobile to remind her mom about the medication. So she was on medication, but still uncontrolled. So our role now, as per the guidelines, to add spironolactone, consider changing her ARB from valsartan to a stronger one, azilsartan. Atenolol, we cannot push the dose because she's already, her heart rate is 60 beats per minute. So we can consider carvedilol, which will control her blood pressure without affecting the heart rate. She's on diuretic. Should we consider chlorthalidone, furosemide, which are stronger diuretic? She's on amlodipine. Should we consider another calcium channel blocker, nifedipine? What are the doses of the medication? What are the intervals between the medication? We should add it one by one, as we just mentioned. So there is no one size fits all. Every patient is a different entity, taking careful history and managing his medication and adjusting small dose by small dose and seeing him on regular interval is really crucial. So our take-home message, please discuss with your patient the target blood pressure, advise him for home blood pressure measurement, of course low salt diet, consider secondary hypertension, refer him to endocrinologist, add spironolactone, and please use combination pills for your patient. Thank you very much.
Thank you very much. Thank you very much, Dr. Iman. That was really a very educational and very comprehensive lecture. There's one interesting thing you mentioned in the beginning about the pseudo-resistant hypertension, which is there's a syndrome called Munchausen syndrome, which is a very common syndrome. I don't know if you hear about it or not, but this is basically a factitious disorder where the patient thinks he's a patient and he's not a patient. And he goes roaming for what we call it shopping for doctors. So he goes from a clinic to another, where he just needs more like an attention. So those patients, they have high blood pressure in the clinic, which is a bit tricky because when you follow up with them, you see that the blood pressure is a bit of normal at home. So how do do we confuse them with white coat hypertension, or when we take more history, we find out what they have about this factitious disorders, and we prefer to refer them to a psychiatrist? What do you think about this kind of patients?
Thank you, Dr. Fadi, for this interesting question. I really had such a patient last week. Referring them to psychiatry is kind of tricky because unfortunately psychiatry consultation is not covered by insurance except for locals. So I usually refer them to neurologists, and even from his mind, when you tell him, I would like to refer you to a neurologist, he would accept it more than psychiatrist. A neurologist, I believe they are authorized to prescribe antidepressant and anti-anxiety to them. But this can only be done after ruling that he has really hypertension. After using ambulatory blood pressure for this patient, let him check his blood pressure on different occasions at home. And then when he comes back, you will talk to him, you'll make sure that his blood pressure is normal most of the time. And you will explain to them that you have a normal blood pressure. I believe it's anxiety. I believe it's stress from your work. And at that time, you can refer him to a neurologist or psychiatrist according to his condition.
Perfect. Thank you very much. We have room for a question. Yes, please, Dr. Amal.
Thank you, Dr. Ayman, for your elegant presentation. But I have one question or comment about the echocardiography in diagnosis of hypertension. I used to use echocardiography from baseline to diagnose first. If the patient is primary essential hypertension, I should check LVH and the diastolic dysfunction because it will affect the management. Second, to exclude secondary hypertension. How many patients, especially young, you will find aortic lesion, congenital like that. So echo, it should not be depends on ECG, either normal or abnormal. It should depend as a baseline for diagnosis. Second, for your case, excellent case, but also if we will follow the guideline, it will be better. Start double therapy and recommended ARBs, calcium channel blocker, if not controlled, triple therapy, if not controlled, you can add other medication. Thank you.
Thank you, Dr. Amal, for your interesting comment. For the patient, yes, she was already on a combination of thiazide diuretic, amlodipine, valsartan, and atenolol. She was already on these medication. Then we started discussing what to do for her. For the comment about the echo, we'll be facing a strong rejection from the insurance if we do echo for every hypertensive patient. Yeah, but I mean, it will cause problems. So we start by ECG, and if the ECG has any abnormality at that time, we can be justified. And this is even the recommendation of the European Society of Cardiology. And I do understand that many of them, they have LVH and diastolic dysfunction, but this is the situation.
I agree with you, Dr. Amin, because we have usually on the guidelines as well, you cannot do an echo for every single hypertensive patient unless there is a target organ damage or symptoms related to hypertension. But on many occasions, like you said, Dr. Amal, we can find like further than a grade 1 diastolic dysfunction, like patients who have long-term hypertension undiagnosed. We use the tissue Doppler nowadays to check if there's like diastolic dysfunction. We measure the LV filling pressure.
Dr. Fadi, it should not be occasional. It should be like ECG. Cannot be occasional. How? How I will diagnose my patient? How I will give the correct medication for him? First, you should exclude secondary hypertension.
This is young patients. I agree with you.
In any patient, doctor, you should first exclude secondary hypertension. If excluded, and also you exclude the patient has diastolic dysfunction, management will be different. So never echo, it will be occasional. It should be the most common after ECG. So same sequence as you are asking ECG. All of us know that ECG, how the specificity of ECG? 27%? So what do you benefit? Almost your patient, all your patient normal ECG. So how to do echo for patient with hypertension, to start medicine for him on ECG? Cannot be, doctor.
The actual truth that we do echo basically for most patients who have hypertension. But Dr. Iman was talking about the guidelines, because actually, yes, the guidelines say that we cannot do for every single patient with hypertension an echocardiogram. That's why the insurance is using this point not to approve it. But you can use also other things to convince the insurance to do echo for this kind of patients. For young patients, it's mandatory to do echo to rule out other secondary causes like aortic coarctation, for example, right? You have even to do ankle brachial index to these patients, a lot of workup. Sometimes you have to go for renal Doppler, renal artery Doppler as well for those patients. Dr. Muhammad, yes.
The use of echo also is very crucial, especially in patients with labile hypertension. Blood pressure is still in the gray zone. You want to start blood pressure medications or no? So at that time, echo will be useful. I will use it if there is LVH or diastolic dysfunction. Now I will go with treatment. If there is no LVH or like that, I can go for lifestyle modifications or whatever. So maybe this is the more use about to go with echo more.
I mean, we can argue about it, and I respect everyone's opinion. But again, this is the recommendation of the guidelines. And remember, we're talking about 40% of the population here in UAE. They have hypertension. This is above the average percentage in the whole world. So we cannot do echo for every hypertensive patient. Hypertensive patients are followed by GP, by family medicine, by internal medicine. All of these subspecialties, they are seeing the hypertensive patient and managing. If we put now that every hypertensive patient should do echo, we cannot. Even our resources and our echo machine, they cannot do echo for every hypertensive patient in UAE or even in Abu Dhabi. So the guidelines is, yes, it's not fair for every patient. Again, you as a clinician and Dr. Amal, everyone has his own method of assessing the risk of the patient, and you will decide who really deserves to fight for at the insurance and get him approval for echo. But I don't think that every hypertensive patient can go.
Another small comment, if you please, Doctora. Regarding also selected groups, like in patients with diabetes or all elderly patients, I think blood pressure measurement is not enough. We should do in these cases also segmental blood pressure measurement to screen for peripheral arterial diseases. So being hypertensive and hyperlipidemic and diabetic or elderly, at that time, we should go for more sophisticated blood pressure measurements like segmental blood pressure, which I think many of our hospitals is not doing.
Yes, I agree with you, and it's already mentioned in the guidelines. Going for ankle brachial index for this patient is important, and even Doppler for brachial artery or femoral artery if you have a suspicion about any calcification or any peripheral vascular disease.
Thank you very much for the interesting discussion, and I think the discussion is the reason why every year or 2 years we see newer and newer guidelines. You know, if everything was just black and white, we wouldn't be seeing these guidelines being changed. So a little bit of dynamism exists in the disease process, and therefore these guidelines keep changing. With this, we end this session. Thank you very much to all the speakers for their wonderful talks.